Hello, everybody. Welcome to the Honesty Sessions webinar. This is a five-part webinar series exploring the lifelong impact of preterm birth. Hopefully, some of you will have maybe seen our first two webinars, but they're live on our YouTube channel for those who were unable to attend. I can just see that lots of people are still arriving, but we'll make a start. I'm Vicky. I'm part of the 99 NICU web forum team, and this webinar series has been put together in collaboration with the Adult Preemie's Advocacy Network, or APAN, who have put together a really great series of speakers throughout November to commemorate World Prematurity Day. I'm going to really very soon hand over to Lauren, who is one of the founders of APAN. But just in terms of some housekeeping before we get started, the meeting is being recorded, or the webinar, sorry, is being recorded, and in the next few days after the webinar, we will put that onto our YouTube channel so you can watch it there. Please let us know where you are and where you're from, and whether you're an adult born preterm, a parent, or a health professional. Please let us know where you're dialing in from today in the chat. We've got over 188 registrations for this webinar series from all over the world. So please do put those details in the chat, and it's a pleasure to have you all here. We will also have questions and answers throughout the webinar. So please put any questions to either of our speakers today in the chat, and we will do our best to field them and put them to the speakers throughout the session. If we don't get a chance to cover all the questions, then I'm sure that our speakers will be able to respond to them outside of the webinar. I haven't checked that with them. I've just thrown that in here. But they both seem happy, so that's good. I'm going to start the webinar, and I'm going to hand over to Lauren to introduce herself and our guest speaker today. So over to you, Lauren, and thank you very much.
Thank you so much, Vicky, for that lovely introduction, and welcome to everyone viewing. I'm Lauren. I'm co-founder of the Adult Preemie Advocacy Network. I was born at 26 weeks gestation and weighing 430 grams. My mum had preeclampsia, and I'm 36 years old, so I'm considered a bit of an old fogey in terms of preterm birth. I am so delighted to welcome Michelle, who is joining me on this webinar today. We're aiming to talk about fostering communication between patients and possibly parents and clinicians, and why birth history matters to both of us across the life course. So over to you, Michelle, if you'd like to introduce yourself.
Hi, I am Michelle Kelly. I am a pediatric and a neonatal nurse practitioner. I teach at Villanova University in the United States. I am a researcher who looks at and who studies and tries to bring awareness to the health risks of adults and adolescents and adults who were born preterm, and how that preterm birth history affects their long-term health. And Lauren and I have teamed up on an occasion or two to try and bring both pieces and both perspectives, both the adult preemie and the provider voice. As Lauren well knows, I will speak to anyone, anywhere about the importance of recognizing birth weight and gestational age long past toddlerhood.
So I'll just do a little bit of background onto how me and Michelle actually came into contact in the first place. So in 2020 was around the time that people like myself and Juliet were starting to connect as adults born preterm to share our experiences. And within this, we were finding really common themes, such as ongoing challenges with education and with our health, possibly mental health, neurodivergence. There's a whole range of things that possibly may be impacted. And within that, we started to realise that there were no charities or support systems in place beyond for parents and beyond those really early years. So we decided that as we're quite a resilient bunch, we might have a go at this ourselves and to see where we got to. So fast forward to March 2021, and I was very aware of the body of research that is continuing to grow, of healthcare challenges and the things that I've just mentioned. But I was really floundering with, okay, we know there's lots of things. Where do we go first? What bit is the most important? And the answer is really all of it's important. So whilst having a good search on Google Scholar, I stumbled across Michelle's paper, and it's probably one of the most heartwarming papers I have ever seen. I think I spent a good half an hour half crying, half jumping around with joy, because this was the first paper I had ever seen that acknowledged preterm birth as a risk factor, but was also providing some suggestions and some guidelines of some monitoring we could put in place at a very primary care level. So this paper was addressing preterm birth history with clinical practice recommendations across the life course. And it isn't an underestimation to say that this paper changed not only my life personally, but also the direction of our advocacy network and the direction that we went into.
So there's a fantastic lesson to be learned there, that as a researcher, we love having people who our research speaks to reach out to us. And Lauren did just that. She emailed me and she reached out, and we have been working together to share this message and share this voice ever since.
So maybe I'll give a little bit of background of my journey and my healthcare. So in my early years, my preterm birth history in terms of my health really didn't impact me that much. So I was very aware at school and things that during physical education lessons that I wasn't able, for example, to run as far as my peers. This could have possibly been misunderstood as actually I was quite sporty in a tick box kind of way. So I was good at ballet, I was good at gymnastics, and I suppose from a very on the paper level, you would have thought Lauren's really fit and healthy. It's great that she can do these sports. But actually, all of the sports I was involved in required very short-term energy bursts. They didn't require that cardiovascular respiratory reserve that you may have assumed that being sporty I would have. So if we fast forward quite quickly to around 10 years ago when I was 26, at this point in my life, I was working as a canine hydrotherapist. So this is where we treat dogs in water to help them recover from neurological conditions or orthopedic conditions, arthritis, things like that. And we use water to help them build up muscle and regain function. So I was in a really physical job, which required quite a lot of muscle and resistance. And up until that point, as I said, I've been relatively healthy. Quite suddenly, I began to lose skeletal muscle and I was becoming incredibly fatigued. So I was able to go to work, come home, fall asleep, be woken up to have dinner. And this was a completely alien concept to me in terms of my health. So I went to my GP, who was actually quite surprised. I think we had a bit of a giggle initially because they were so surprised that I turned up in their office because they had never seen me previously, apart from sort of recurrent chest infections and throat infections, which if you're born preterm, you may be at increased risks of. So as a result of that, I had some routine blood screening on the back of that what we were seeing was unusual and that they hadn't seen me for a long time. This was shocking to me. When the results came back, we found that I actually had chronic kidney disease and diabetes. And this hit me and my family really completely out of the blue. And within this, what we were seeing was that I was obviously symptomatic in terms of losing around 6 kilos of muscle and being so exhausted. But the symptoms that we would normally associate with these conditions, such as being thirsty or excess urine output, was something that I really wasn't experiencing. And in terms of being referred to a consultant, I was falling below this threshold criteria of my GP being easily able to refer me to a consultant. This was easier for to nephrology for my kidneys, but with the glucose regulation issues, this was a real battle that I did try to address myself in terms of contacting the local diabetic nurse team. However, I was hitting a brick wall where, again, I wasn't meeting threshold criteria. I'd been online and Googled and had become aware that preterm birth may be a risk factor for diabetes, but this really wasn't being heard or understood by the team that I was dealing with. And at 26 years old, I am a little bit embarrassed to say that my mum had to stand up and really champion for me. She got on the phone and, with her magical powers of persuasion, got them to refer me to consultant level. So when I saw the consultants, they were actually very open to me discussing my preterm birth history. They were very open and honest and said that as clinicians, they weren't aware that they had seen any other patients like me, but on discussing, they realised that actually maybe they had seen them and they weren't aware. So particularly with my diabetes, we really had to work together to try and manage my glucose levels. Trying to think how to word this. So with my glucose levels, we weren't seeing a typical trajectory of increase in glucose that would be associated with food and that kind of thing. So there were a lot of question marks there about why this was actually happening. And the conclusion we really came to was that perhaps I'd had an underlying virus that had perhaps triggered this mechanism, but fundamentally perhaps that this was due to chronic stress levels and also tiredness associated with insomnia. And this was really something that also flowed into my kidney consultation, where, again, we didn't really have that much understanding as to why this was happening. But the consultant then made me aware that your gestational age can dictate the number of nephrons that you have in your kidneys. And the way he put it to me was that every individual will have their own threshold for coping. And that for me personally, I had reached that threshold when my body was now starting to say, actually, we're not able to cope anymore. So within that consultation, I was advised to stop taking some medication that my GP had prescribed. And I'm going to be very careful here and I'm not going to name it. And from this point of view, I am entirely sure that for most of the population, this medication is widely prescribed and is very effective. But for me personally, the consultant made me aware that this medication would stop me leaking protein through my urine, but that actually what was happening was it was continuing to trigger this mechanism of reduced filtration rate, and that quite possibly we'd see improvement if we stopped this medication. And actually that was true. So within about 2 weeks, I did another blood test and my kidney function had gone from borderline sort of stage 3, where it was deteriorating incredibly rapidly, to back up to around 85% normal. And this is something that has really continued across the next 10 years of my life up to today. That yes, my glucose levels and my kidney function levels, they are a little bit transient and they're up and down. But I can definitely correlate this to what is going on within my life personally. If I'm a bit tired or I'm a bit stressed out, such as maybe doing these webinars, that perhaps we might see a little bit of deterioration there. But we haven't seen a dramatic decrease in a way that perhaps we were thinking when I was originally presenting with these symptoms. So there are a couple of things here that really stand out to me within that lived experience. One was the real lack of awareness of prematurity impacts across the life course, that this information that we're seeing within academia just isn't flowing through either at all or quickly enough to have an impact on the patient population. And the other thing is quite personal, and I apologise, Mum, if you watch this webinar back, but my key memory from that time is not actually particular concern about myself. It was following that appointment with my kidney specialist, where he made us aware of nephron numbers and gestational age. And it is having to, on the way home, having to ask my mum to pull over in the car because she was sobbing. Because all she could say to me was, "Lauren, I am sorry. Nobody told me that there may be impacts later on." And that will stick with me forever. So I am very aware that the evidence is mixed. We don't have an almost tick box checklist of if you're born at X gestational age, these are the definite outcomes. But our parents deserve to be aware that we may have risks, because that then flows through to that individual as they get older, as they need to advocate for themselves. So we can make informed choices about things that we are doing.
Lauren's story is poignant, and she tells it so very, very well. But it is also a story that I have heard over and over again. So regardless of country, in the United States, we're not any better in terms of acknowledging the importance of preterm birth across the lifespan. I was educated as a primary care nurse practitioner, I'm afraid to say, in 1997. So I'm a little bit of an old woman here. But the providers that of my generation were educated and were told that preemies catch up by the time they're 2 or 3, and those who don't catch up are very obvious, and everybody else we don't need to worry about. And as Lauren shared, in her early childhood and adolescence, she actually appeared to be very healthy and normal. And I never want this message to come across to parents that we are saying your child will definitely have this or will definitely have that. Most of the conditions that we have greatest concern about, so kidney function, hypertension, depression and anxiety, they're all conditions that exist in the regular population, the term-born population. They occur more frequently in people who were born early, which means we as providers and clinicians have to do a better job of asking the question and acknowledging that people who were born early are at increased risk so we can intervene earlier. So we don't get to the 26-year-old Lauren who has suddenly lost all of this weight and is having all of these issues. If there were, recognition of this as a potential, when Lauren was 20 or when she was 18 or even when she was 16, there may have been some things that we might have done different, some medications that we avoid, some lifestyle choices. Lauren is a very healthy young woman, if to look at her, right? But there are a lot of people who are born early who struggle with their weight. And particularly here in the United States, we go from, force feeding babies in the NICU and getting them, to gain weight because weight gain equals lung growth. And we have this mentality that we need to get them to grow. And then unfortunately, we have some families that carry that in through their toddler and young early childhood years, and we actually have children who are quite overweight, and that exacerbates some of these chronic conditions, some of these problems. So from a health teaching standpoint, we need to have these conversations as early as possible with parents. I have them as often as I can with providers. I teach in a college where we have nurse practitioner students and undergraduate nursing students, and they've all heard Michelle Kelly stand up and have this conversation because it is a soapbox I stand on quite often. But it's important for us to have this question or to ask the question and understand what the answer means.
So as part of our advocacy network, probably the most common reason we have emails and people contacting us is parents and adult born preterm, almost at that point of exasperation of I have tried to raise my preterm birth history with my provider, but I am not being heard.
Mm-hmm.
So how can we begin to try and unpick this from both sides? Because it's wrong to feel understandable, but from a patient, it's wrong to feel frustrated with a community such as primary care who are dismissing us, but it's because they genuinely do not know that they need to be aware of these issues.
There are a couple of articles. I put the link to the recommendations that I wrote years ago, but there are also some other really great ones that are good resources to take to your provider visits if you are concerned about whether or not they're acknowledging, or if you have health conditions that you think might be related to prematurity. The reality is we don't know all of the information, and particularly here in the United States, all of the research, the majority of the research is coming out of European countries. We don't have a national healthcare system, so it's very difficult to track patients. Casey Crump and his work with the Scandinavians have a better, anything that's been written by Casey Crump related to long-term preterm outcomes is absolutely worth reading. And we can definitely help in that mechanism. I'll put my email in the chat. I really, as Vicki suggested, I am super willing to answer questions or to provide articles if you're hitting firewalls, and if there's stuff you want to read or families want to be able to take with them to visits. I am very happy to make sure to share that on a personal level so that I'm not infringing on anybody's copyright, but to get it to you.
Thank you, Michelle. That's really, really helpful. So do you think we could do more within teaching healthcare professionals, so in terms of embedding prematurity across the life course into the curriculum? Could we offer continuous professional development? Are there avenues we could go down that way?
I think absolutely there are lots of opportunities for that. I think, there's an educational principle, right, that if you teach the young, the old will follow. And really getting it to students and interns and residents is a great way to reach the more established providers. the generation of providers who perhaps are less inclined to follow the most current research. So reaching medical students and residents and nurse practitioner students and truly undergraduate nursing students, pre-licensure nursing students, that's a way to change healthcare, right? And to just put all of this sort of into context for parents and families that may be listening, this is relatively new information, right? This is relatively new information because the life expectancy of people born early is much more, has expanded, right? We have individuals surviving at younger gestational ages and living longer lives. So this is an evolving area of science. It's a new area of science because of the successes that happen in the NICU or in the neonatal intensive care unit, now spilling on to adult providers. When you consider that, for my context, 12% of people born in the United States are born early, that means every provider, regardless of their specialty, is taking care of patients who were born early. They just don't know it.
So when we talk about recording birth history, what kind of information is useful to provide? Is it just gestational age, or do we need to consider birth weight, perhaps cause of prematurity? So for example, whether that's spontaneous labor or, in my instance, preeclampsia.
I think absolutely as much detail as possible, definitely gestational age and definitely birth weight as an absolute minimum, but also whether it was a planned early delivery or a spontaneous early delivery, family history of prior early births. We know that women who were born early are more likely to deliver early. Okay, not a 100%, but there is a familial risk, a family history risk. What we don't know 100%, and there are some really good science suggesting that some different causal mechanisms, but we don't know whether you are more likely to deliver early because of some genetic predisposition or whether it's from an environmental exposure. So your social setting, your structural setting within your, where you grew up, and then how you then, where you're growing, where you're living or what you're experiencing as a pregnant woman or a pregnant person. We know that environmental pollutions and all of these other things play a role in the risks for being born early. Well, if those risks exist and you were born early, right, we're compounding risk. And those are those questions. And that's the concept that we want to sort of embrace, that compounded risk, right? So all of those pieces are important parts of changing how we track that and how we understand it, because research cannot be done if we don't have the information. And I love an electronic health record. I love being able to look back, but if the data was never entered, I can't look back and see whether or not that person was born early. So we really need to make sure we're sharing that information with our clinicians. And as clinicians, we need to be better about asking it and tracking it.
So how do we encourage healthcare providers to ask the question? And also within that, are we doing enough to follow up at preterm patients?
So how we convince them, I'm not sure. Again, I've made as a compelling argument as I can and will continue to do that just about anywhere anyone wants me to come and talk. And there are other researchers and clinicians that are doing that as well. The adult preterm Adult Born Preterm International Collaborative is a fantastic research arm, and they are working hard at some of these components, and it's an international collaboration. Some of it's going to be coercion, right? Maybe you need to bake them a cake. I don't know. You know, bring them an article and a sweet. Something we can do to make them understand, or to, you know, to get them to ask the question. Lauren, what was the second part of your question?
It was about follow-up. So are we doing
Follow-up.
enough to follow up?
So follow-up. The problem with follow-up is that follow-up costs money. And just quite frankly, follow-up costs money. And for the vast majority, and I'll speak to the United States, the vast majority of people born early in the United States are born between 32 and 36 weeks of gestation. They automatically do not qualify for our follow-up programs because they were born close enough. They did well. They may not have spent much time in the NICU. The younger gestations do, but they're typically only followed until about age 2. We do not have a mechanism for doing long-term follow-up in most areas of the United States. There are some great programs. The University of Rhode Island has a fantastic study that has been following preterms that were born in the mid-80s, and they're in their 35-ish now. And that long-term study has gone on. It's been led by a nurse researcher named Mary Sullivan. And it, you know, so research like that is great, but it's not, it's research. It's not long-term follow-up in terms of healthcare, right? Do I see a day, or do I dream about a day where we have preterm specialists that follow people well beyond the NICU? Absolutely. I think just as we are starting to see congenital cardiac programs, where so we have people that were born with congenital heart disease, they are now being, you know, adult providers are going, what's attached to what's that anatomy? Those adults are now being followed, you know, they were followed to the edge of childhood, really almost into adulthood, by a lot of pediatric cardiologists. And now we're starting to see some bridge programs where we have adult cardiologists that have a pediatric specialty or a background, or have spent some time with pediatric cardiologists to really start to understand these long-term outcomes. And I think we may find that coming soon, or I dream about it coming soon, because I really would like it to happen.
That's brilliant. Vicky, are there any comments or questions in the chat that we could discuss or answer?
Not at the moment. There is a comment about no electronic medical records for those born in the 1990s.
Right.
And in the UK, at least, we still don't have electronic records across all of our NICUs yet. But no questions yet. I'm sure that everyone is just absorbing all the things that you guys are talking about.
Michelle, have I missed anything off our usual list?
Well, I think one of the things is addressing parents and recognizing that sometimes parents have this fear of making a child appear vulnerable. So we want to have our child that was born at 30 weeks or 28 weeks catch up and be doing as well as their peers. And I never want someone to misunderstand me or assume that that child cannot do as well as their peers, because the vast majority of kids born early really are, with the right supports, with the right early intervention, early in their developmental stages, they really do go on to lead healthy, productive lives. What the barriers that can be put in place or that may come up later are these chronic health conditions or the need for speech therapy or occupational therapy or some other supports that exist longer than we expected them to. So, when I speak to providers, I always speak about maximizing potential and making sure that the kids who were born early have all of the supports that they need to maximize their potential, and that parents are taught not to assume that their child can't, but to recognize that sometimes their child can be doing really, really well, but everyone assumes that that they're doing okay, right? And maybe the parent is the only one who knows that at home that child is actually really struggling to get that math work done, or is really struggling with the higher expectations of second or third grade math, right? Second grade math is hard. You have to borrow and carry, and there's lots of extra things to it, right? And executive function is one of the concerns that sometimes preterms struggle with. Well, that doesn't mean that they're not going to be able to master that skill, but it might mean that by second grade, they need some extra help to get ahead, to be able to be supported. And I've had parents, when I work as a primary care provider, I've had parents say to me, "Oh, I don't like to tell anyone that my child was born early because I don't want them to appear vulnerable. I don't want someone to expect that they can't." And I really try very hard to change that focus so that it is, I'm not expecting that they can't. I want to make sure that they can. I want to give them the supports they need so that they continue to be able to. That as the bar gets higher and expectations of academics or sports or social interactions, as they all get higher, we make sure that the kids have the skills they need to continue to do so. I've had providers say to me, "Well, there's nothing I can do about the fact that that child was born at 30 weeks. Why does it matter?" Well, it matters a lot, right? And yes, there's nothing we can do about the fact that that child was born at 30 weeks or at 28 weeks or at 32 weeks. The people in the NICU and the obstetricians, they do a great job. And that's a whole bucket of research that I think is done, amazing work over my lifespan. But just like we tell adults who have a family history of heart disease or a family history of diabetes, I can't change the fact that your grandfather had diabetes or that your father had diabetes, but I can change how that risk expresses in your existence. So how it is expressed in your life. So in the sense, in the context of diabetes, we know that a patient has a strong family history of diabetes. We work extra hard on healthy lifestyles, on healthy eating choices, on exercise, and making sure that they maintain a normal body weight. And when we start to see that fall off, we intervene sooner, right? So we consider medications a little bit earlier because their family history is so strong. And that's the shift I'd like to see from a clinician standpoint, right? Recognizing what the risk means and intervening sooner. Right now, intervening sooner might mean that you're using the same medications that you would be using for anyone else. In the next 5 years or so, I think we're going to have some targeted medications that work better on preterm kidneys or work better on preterm hearts in terms of hypertension and things like that. There's some really good research that's coming out, and I think as we recognize more that people born early are a population to be studied independently, I think we'll have better medications and better treatment choices.
Those lifestyle modifications and awareness is so important as an individual. So I'll use myself as an example again. If I take my nephron number and my kidney issues, I hope that when I reached adolescence and going into 18, because that's the legal drinking age in the UK, I like to think that if I had been aware that I needed to think about what I was doing, that I could have made at times slightly different choices. I also have joint issues, so I'm hypermobile in my joints, and I also had rickets when I was born. But again, there's use of anti-inflammatory medication, which I was using really regularly because it was helping me. Again, if I'd known that previously, could I have looked at alternative support like physio or different medications that would have helped me? You really can prevent some of these issues from happening with awareness and an ability to make informed choices.
I see there's a question from Dr. Johansson. What are the big bottlenecks to overcome, and what are the potential public health consequences of the currently poor follow-up? And, you know, it's a numbers game again. So if you have 12% of people who are born preterm annually, that means that you're going to have 12% of your aging population. You know, we haven't budged that number in the US very much. It's run between, you know, 10% for decades. So that means 10% of the population at a minimum has these adult health risks. So that's a public health planning issue in terms of you know, the conditions that are most common: hypertension, reduced pulmonary function in adulthood, the mental health concerns, right? All of these pieces play into the long-term health, and that affects the overall health of your population. So from a public health and planning standpoint, we need to think that way. From an educational standpoint, we need to think about the number of kids that are in our elementary schools or primary schools and secondary schools and how much support they need. Several years ago, I did a study where I looked at the need of support services throughout high school, so through primary school and secondary school. And we have kids that are born early that are still requiring more supports in secondary school, which is pretty tough to get in the United States, for it to continue that long, because we try and normalize kids and we try and get them back into regular education and without some extra supports. So, you know, and that study looked at all gestational age. It wasn't just looking at the 23 or 24 weekers who might have some mobility issues, right? Or some intellectual disabilities. This was looking at all gestational age. They all had an increased overall risk. So that's a planning standpoint, you know, and when we talk about what, you know, the societal economic burdens of providing services long-term, we need to plan for that because we have a whole population, a whole component of our population rather that has been born early.
And there is definitely a need to look at this retrospectively for the older generations born preterm, because our experiences are that certainly within education, there can be assumptions that you're lazy or you're not trying hard enough because people don't understand. When trying to access healthcare, this can lead to insinuations that we have unnecessary health anxiety or hypochondria. And I think if we look at the evidence, there is a difference between just being anxious generally to actually having valid concerns with some evidence there to back up your viewpoint. So we really do need to work to try and address that retrospectively. I know that's really challenging, but it's something that's worth a discussion.
Yep.
Well, I mean, I think that there is a lot for us all to think about here, and we are starting to get comments and questions coming through now, quite thick and fast. one question that's come in is, are there any countries in particular that are leading the way in terms of understanding both the short and long-term effects of preterm birth?
I know that there are researchers in, from my work with the APIC, which is the Adults Born Preterm International Collaborative. There are specific teams of researchers, Samantha Johnson, Peter Wolke, that are doing really great work. I don't know from a care perspective that there is any country that I would hold out there as saying this is the model. I think we're all sort of in this same stage of figuring out how we make it work within our own healthcare systems.
Yeah, from the patient perspective, that's definitely what we're seeing with APAN, is that this need for better awareness is global. I was surprised, I think both me and Juliet was surprised when we first started this. We were maybe a little bit naive in thinking, as we're both in the UK, perhaps there was a country that was looking at this in a little bit more detail, but that really hasn't been our observation so far.
And also, this is just my question, I guess, or my comment based on what you've both said, is that there is going to be presumably some inequity as well in terms of people who have got access to different resources, and, for example, people who can pay for different things that they need in terms of long-term physio, I think was mentioned as one thing. So I guess that is also potentially a challenge.
I think it's also a challenge because there is no specific one problem, right? So if you have diabetes, you know that your blood sugar is the problem. It can be caused from a bunch of different reasons, but we see endocrinology to manage their blood sugars. Because preterm birth can affect so many body systems, it's really it almost really does belong in primary care because it's looking at the whole body, but that they're not, they haven't necessarily kept up with some of the, or they find challenges with figuring it out. So I think I think that adds layers.
I really like the idea of an integrated adult born preterm kind of healthcare setup that you talked about earlier, like a professional who is going to see you for that whole journey. I think that sounds like quite an exciting potential development. There's a couple of things that are almost related, actually. So one is a comment from Diane, but it links to a question that I've been sent, actually, that's not in the general chat because they were having trouble typing it in. But Diane says that her daughter was born at 22 plus 6 weeks and found that accessing care outside of the NICU bubble, if she wasn't proactive, there weren't any questions about birth history, which was definitely a barrier. And that there's definitely a big piece around history taking, but only if the questions are asked. And she comments that it's a great pressure for parents who might be thinking, did I miss anything in a situation that's already stressful? And the question that I have been asked to ask, actually, is what more can we do to make sure young adults have access to their medical history when needed? And how can we ensure that infants discharged from NICUs have access to their own information about their medical history, which sort of links to Diane's comment about the stress that puts on parents?
So I can speak to what I recommend to my patients, and that's to get a copy of the NICU discharge summary. You probably don't need the whole record, but that discharge summary, or that will give a decent overview. That's a really important piece of information to access from your NICU and to maintain in your own personal health records so that you can provide that information. I think making sure that your children know their birth story, that they know what happened, is important. And we did some qualitative research with the 30-ish-year-olds from the University of Rhode Island group. And it sort of falls into three buckets. I never think about being born preterm except when you people call me for my research study, to the I know I was born preterm, but I'm fine and it doesn't it doesn't have anything to do with my life. And then this other group that says my preterm birth story was influenced everything that happened in my life. My mom's, my mother telling me that I was so strong, that I was a survivor, that I was, a miracle, all of these words that show the resilience that people born early really do experience throughout their lives. Probably somewhere in the middle is the sweet spot in terms of not making them out to be, this incredible miracle, because sometimes that can put a lot of pressure on adults or children. But making sure that they're aware of their story and that they know is incredibly important. And as a parent, making sure that you are supportive and are willing to tell the story, and know that most prematurity happens without a good reason. So you didn't miss anything. You didn't, not do what you were supposed to do. And if you love your child unconditionally, your best is good enough. And we just need to make sure that parents are supported, and that as parents, we support our children as well.
Yeah, I think there's a follow-up question, I guess there, isn't there, about so most people, I think, on the call, in terms of profession are neonatal. I mean, that would go to our reach as 99 NICU. But obviously what we're talking about is primary care and longer term. So I guess what can we do, or how do we get that
Talk to your friends.
Yeah.
Because, and we are preaching to the choir, right? We're talking to the neonatologists who are so, and neonatal clinicians who are so good at caring for them in the NICU. But I think making sure that when we're getting to that going home stage, right? And this is not a conversation for, week 1 of resuscitation, and we're all, where we're just wanting to make sure that the baby is eating and breathing and those things. But when we get to those later stages and the conversation about, getting ready to go home, I think my NICU colleagues, I always ask them to make sure that they're sharing a message of, even if your child looks like they're doing great, and even if they're making all of their milestones, please make sure you keep sharing the story that they were born early, so that we can catch things before they become a problem.
Also utilising those later assessments, so neurodevelopmental and mental, that's a good starting point to open the door for conversations.
Mm-hmm.
And yeah, we've got we've got a comment here as well that we should be communicating with adult GPs when we transfer patients, health authorities, social media. I feel we might be starting a movement.
Well, and education, and educators as well. So the Preemie schools that Samantha Johnson has worked through, which is really great from an educational standpoint. We don't have anything like that in the United States. That's a bucket list of mine. But educators tend to think that the primary care or the GPs are worrying about their development, and GPs and primary care providers tend to think that if there's an educational problem, the teachers will identify it. And the reality is, and I've learned from both groups, that neither one of them is willing to take that next step. So it ends up falling on parents who say, hey, this is happening. So it needs to be, all 3 points of the triangle involved.
What was the name of the organization you just said then? Was it
Preemie? Lauren, do I have that right? It's Preemie schools?
Yeah, Preemie schools.
Mm-hmm. And is that kind of international? Is that an international organization, or? No,
it's in the UK. Samantha Johnson is the researcher.
Yeah, and the charity that's linked to it is The Smallest Things.
Yes. Mhm. So they actually will give the school a medallion or a certification that says that a certain percentage of the teachers in that school system are, recognize the risks related to prematurity.
Perfect. We put that information in the chat for people. I think probably we might be starting to sort of bring everything to a close. Any last questions that anyone wants to get in the chat before we end, then please do. Diana said, as a parent, it's scary to think how my daughter's premature birth might impact her health later, but I would rather be aware of the possibilities than be caught by surprise. And she feels that most parents would be in the same boat. And so I guess, where is that timing? I guess that, like you said, Michelle, you don't want to necessarily have that in week one, but is that is that discharge? Is that a continuous message that is kind of drip fed throughout the stay? Is that a 2-year follow-up? Some babies won't get a follow-up, as we know, the late babies born late preterm. How do we tactfully, I guess, start that conversation?
I think we have the conversation just exactly the same way we have the conversation about, needing RSV vaccines or, respiratory health or, paying attention to, chronic lung disease, right? We just need to get better at it. And the more we do it, the more it will feel like a normal conversation. And so if it becomes that consistent message and we start with the families, while they're in the NICU, then it's not the, as Diane said, parents want to know what comes next, and letting them know that this is a possibility, right? Not a foregone conclusion, but a possibility of what could come next and how they can support their child best. Then I think we're in a good space. We just need to do it.
That sounds like a really positive message to end on, perhaps. Any final comments from either of you, I guess, before we draw the webinar to a close? Lauren, anything else you would like to say?
Just to echo the message, just to be brave. This is something that is not a guarantee, but the more we talk about it and the more open we are, it will help to lead to change about asking about birth history, and that can really influence that individual that perhaps you're looking after in that incubator and change the outcome of their lives.
Any final comments from yourself, Michelle?
No, just I think, the more people we share this message with, the more we are able to start a movement from the ground up. That's how things get changed. So don't get discouraged. Keep sharing the story, and if there's anything I can do, reach out.
Amazing. Well, thank you both very much for your time today and for sharing your stories. We are going to close now, and we will upload this in the next week or so onto our YouTube channel. And Lauren, I'm afraid you sent me some slides earlier that I have not got ready to share. But our next webinar is coming up on Monday, the 18th of November. And that is a panel discussion with a number of people looking at long-term lung health and sort of supported by the BPD collaborative. So please do tune in for that on the 18th of November. And yeah, we'll see you there. Thank you very much, everyone, for joining us. And have a good rest of your day, everyone.
Thank you.
Thank you very much.